Allogeneic stem cell transplant remains the only curative treatment approach that we have in the management of CLL. It comes at real costs. It's only applicable to a rather small population of patients. The vast majority of patients with CLL are too elderly. And it comes at a real significant morbidity and mortality, the morbidity being from chronic extensive graft-versus-host-disease, where the incidence looks probably around 50%, and in most series of mortality around 20%. When we had very stark choices between performing an allogeneic stem cell transplant or having no effective salvage therapy, that cost was a price worth paying. With the advent of the novel therapies that we have, where the response rates are so high, the durations of response so good, and the toxicity profile of the use of continuous agents so low, exactly where an allogeneic stem cell transplant fits in versus an allogeneic transplant, versus the novel agents, is really now very, very difficult to tease apart. There are guidelines out there, and I've been was part of the group that was looking to write the guidelines. But what should come across very strong in the guidelines is there's not real consensus, and they're rather nebulous because there's not sufficient data for us to really be able to say when should we pull the trigger, so to speak, and recommend that someone comes off therapy, or continue on that therapy or come off and do the allogeneic stem cell transplant. So you're left with an almost individualized case, going through case by case what's happening to an individual patient. What we're all looking to avoid is that possibility of missing the window where a transplant could be useful. And we got lots of questions about exactly this issue, that with Idelalisib, Ibrutinib, and now Venetoclax approved, we've got 3 agents we can salvage these high-risk patients back with more potentially coming. And so the transplant, again, is getting pushed further and further and further back.